How to cure and treat anthrax. Anthrax is a disease with rapid onset caused by the bacterium Bacillus anthracis. Most forms of the disease are lethal, and it affects most animals. It can be transmitted through contact with infected meat. Effective vaccines against anthrax are available, and some forms of the disease respond well to antibiotic treatment. Anthrax can occur in three forms: skin, inhalation, and intestinal. Like many other members of the genus Bacillus, B. anthracis can form dormant spores that are able to survive in harsh conditions for decades or even centuries. Such spores can be found on all continents, including Antarctica. When inhaled, eaten, or come into contact with an area of broken skin, they may become reactivated and multiply rapidly. Usually infection develops in plant-eating mammals that eat or breathe in the spores while grazing. Eating is thought to be the most common route by which herbivores contract anthrax. Carnivores living in the same environment may become infected by eating infected animals. Diseased animals can spread anthrax to humans, either through direct contact or by eating raw or undercooked meat from infected animals. B. anthracis bacterial spores are soil-borne. Disturbed grave sites of infected animals have been known to cause infection over 70 years after the animal's death. Respiratory infection in humans is relatively rare and initially presents with cold or flu-like symptoms for several days, followed by pneumonia and severe, and often fatal, respiratory collapse. Distinguishing pulmonary anthrax from more common causes of respiratory illness is essential to avoiding delays in diagnosis and thereby improving outcomes. Gastrointestinal, GI, infection in humans is most often caused by consuming anthrax-infected meat and is characterized by serious GI difficulty, vomiting of blood, severe diarrhea, acute inflammation of the intestinal tract, and loss of appetite. Lesions have been found in the intestines and in the mouth and throat. After the bacterium invades the gastrointestinal system, it spreads to the bloodstream and throughout the body, while continuing to make toxins. Cutaneous anthrax, also known as Hyde-Porter's disease, is the cutaneous, on the skin, manifestation of anthrax infection in humans. It presents as a boil-like skin lesion that eventually forms an ulcer with a black center, eschar. The black eschar often shows up as a large, painless necrotic ulcer at the site of infection. Cutaneous anthrax is typically caused when B. anthracis spores enter through cuts on the skin. This form is found most commonly when humans handle infected animals and/or animal products. Anthrax can enter the human body through the intestines, ingestion, lungs, inhalation, or skin, cutaneous, and causes distinct clinical symptoms based on its site of entry. In general, an infected human will be quarantined. However, anthrax does not usually spread from an infected human to a non-infected human. But, if the disease is fatal to the person's body, its massive anthrax bacilli becomes a potential source of infection to others. And special precautions should be used to prevent further contamination. Inhalational anthrax, if left untreated until obvious symptoms occur, may be fatal. Anthrax can be contracted in laboratory accidents or by handling infected animals or their wool or hides. It has also been used in biological warfare agents and by terrorists to intentionally infect. Various techniques are used for the direct identification of B. anthracis in clinical material. Firstly, specimens may be gram-stained. Bacillus spp. Are quite large in size, 3 to 4 mm long, they grow in long chains, and they stain gram-positive. To confirm the organism is B. anthracis, rapid diagnostic techniques such as polymerase chain reaction-based assays and immunofluorescence microscopy may be used. All Bacillus species grow well on 5% sheep blood agar and other routine culture media. Polymyxin lysozyme diethylus acetate can be used to isolate B. anthracis from contaminated specimens, and bicarbonate agar is used as an identification method to induce capsule formation. Bacillus spp. Usually grow within 24 hours of incubation at 35 degrees Celsius, in ambient air, room temperature, or in 5% CO2. If bicarbonate agar is used for identification, then the medium must be incubated in 5% CO2. B. Anthracis colonies are medium-large, gray, flat, and irregular with swirling projections, often referred to as having a medusa head appearance, and are not hemolytic on 5% sheep blood agar. The bacteria are not motile, susceptible to penicillin, and produce a wide zone of lecithinase on egg yolk agar. Confirmatory testing to identify B. anthracis includes gamma bacteriophage testing, indirect hemagglutination, and enzyme-linked immunosorbent assay to detect antibodies. The best confirmatory precipitation test for anthrax is the Ascoli test. If a person is suspected as having died from anthrax, every precaution should be taken to avoid skin contact with the potentially contaminated body and fluids exuded through natural body openings. The body should be put in strict quarantine. A blood sample should then be collected and sealed in a container and analyzed in an approved laboratory to ascertain if anthrax is the cause of death. Then, the body should be incinerated. Anthrax cannot be spread directly from person to person, but a person's clothing and body may be contaminated with anthrax spores. Effective decontamination of people can be accomplished by a thorough washdown with antimicrobial soap and water. Wastewater should be treated with bleach or other antimicrobial agent. Effective decontamination of articles can be accomplished by boiling them in water for 30 minutes or longer. Chlorine bleach is ineffective in destroying spores and vegetative cells on surfaces, though formaldehyde is effective. Burning clothing is very effective in destroying spores. After decontamination, there is no need to immunize, treat, or isolate contacts of persons ill with anthrax unless they were also exposed to the same source of infection. Early antibiotic treatment of anthrax is essential. Delay significantly lessens chances for survival. Treatment for anthrax infection and other bacterial infections includes large doses of intravenous and oral antibiotics, such as fluoroquinolones, ciprofloxacin, doxycycline, erythromycin, vancomycin, or penicillin. FDA-approved agents include ciprofloxacin, doxycycline, and penicillin. In possible cases of pulmonary anthrax, early antibiotic prophylaxis treatment is crucial to prevent possible death. If death occurs from anthrax, the body should be isolated to prevent possible spread of anthrax germs. Burial does not kill anthrax spores.